Hi, my name is Dr. David Banach. I'm an associate professor of medicine at the University of Connecticut and the hospital epidemiologist at UConn Health. And the topic of this talk will be the treatment of Clostridium difficile infection, a 2019 update. So this update will primarily focus on the 2018 SHEA and IDSA guidelines that were published. These represent an update from the previous guidelines that were published in 2010, and there's some fairly substantial changes that were made in the interim. So the first change was the definitions of categories of Clostridium difficile. Moving at categories from mild, moderate, severe into either severe versus non-severe was a substantial change. So the two categories in the 2018 guidelines are non-severe, which is a criteria consisting of leukocytosis of a white blood cell count less than 15,000 and a serum creatinine less than 1.5. And this is an update from the 2010 guidelines, which categorized non-severe cases as mild or moderate. And notably, in the 2010 guidelines, metronidazole was recommended as the first-line treatment for mild to moderate disease. Metronidazole has been around and in clinical practice for many years, has a long track record of efficacy in the treatment of Clostridium difficile. It's inexpensive, and generally it's well tolerated for this indication. In comparing the 2010 guidelines to the 2018 guidelines, one of the main foci was comparing metronidazole to vancomycin. Both have been in existence for many years for the treatment of C. difficile, and during this time period have been thought to be roughly equivalent for mild to moderate disease. Interestingly, during this time, there hadn't been any prospective head-to-head comparison studies comparing these two agents. I will note that there are some substantial overall changes that have occurred during the 2010 to 2018 timeframe. Notably, we've had increased data showing on the impact of metronidazole on the overgrowth of vancomycin enterococci, as well as some data showing that the cost of administering vancomycin has substantially decreased. In many hospitals, vancomycin is readily available through reconstituted solution, which is a substantially lower cost than the encapsulated forms of vancomycin, which have been available for sale. In terms of comparing vancomycin to metronidazole, the main focus in previous guidelines had been a distinction between mild disease and severe disease. And that largely stemmed from a study published in 2007, which retrospectively compared the outcomes of patients who had mild disease or moderate or severe disease and were treated with either vancomycin or metronidazole. Without going through the details of the study, what this study showed was that following 21 days after treatment, the patients who received vancomycin and had more severe disease had better outcomes in terms of treatment failure, cure, and decreased rates of relapse compared to those with severe disease who received metronidazole. This was really the main data that led to the distinction between metronidazole versus vancomycin for patients who had severe disease. The study also showed no difference between patients who received vancomycin and patients who received metronidazole and had mild disease. Thus, the two were deemed to be roughly equivalent for this particular disease severity. However, some subsequent data has raised some potential interest in the possibility of differences in terms of treatment efficacy for patients of all disease severity receiving vancomycin versus metronidazole. This was a large retrospective study done across the VA system between 2005 and 2013. This study compared patients who received vancomycin to those who received metronidazole, and they included patients who had disease of all severities. The outcomes that were measured included the recurrence rate as well as the 30-day mortality. The study included inpatient and outpatient data and was of a very large sample size. You can see that among the 45,000 patients who presented for the study, 7,449, 16%, who presented with incident CDI, Clostridium difficile infection, developed recurrence. And 22% who presented with recurrent episodes developed a subsequent recurrence. And this shows the outcome when comparing patients who received vancomycin compared with metronidazole. And what the study showed was that among all disease severities, mild to moderate as well as severe, and the overall cohort, there was a decreased risk of 30-day mortality regardless of severe disease among those patients who received vancomycin compared to those who received metronidazole, showing that there may actually be a benefit of an improved outcome for receiving vancomycin even among those patients with mild to moderate disease. Another important piece of data came from a clinical trial that was actually designed to study tolevimir. Tolevimir is a non-antibiotic toxin-binding polymer that was put forth as a potential treatment for C. difficile. In this study, patients were randomized to either receive oral vancomycin, metronidazole, or tolevimir for a treatment course of 10 days. And the clinical outcome was resolution of diarrhea and abdominal pain at day 10. And interestingly, even though you can see tolevimir, which is the white bar in the study, performed the poorest among all of the three different agents, there was a higher rate of clinical success among patients who received vancomycin compared to those who received metronidazole, and that was among all three different disease severities. So I think even though the study showed that tolevimir was not an acceptable treatment for C. difficile, it showed that among different disease severities, vancomycin actually may perform better than metronidazole. Importantly, this is the only prospective study that ever directly compared patients who received vancomycin to metronidazole. And thus, I think it represents an important piece of data in considering whether or not the two treatments may be equivalent or whether vancomycin may be superior. I will point out one other drug that was incorporated into the 2018 guidelines, which is fidaxomicin. So fidaxomicin, which is the brand name is difficile, performed very well in a phase 3 randomized clinical trial which compared it to vancomycin. This was a study published in 2011 which looked at a 10-day treatment course of vancomycin compared to 10 days of fidaxomicin with a primary endpoint of clinical cure. And what this study showed was that in terms of the primary clinical outcome, the two drugs were roughly equivalent. However, when taking into account a secondary outcome, which was recurrence of disease at 4 weeks post-treatment, you can see that fidaxomicin actually outperformed oral vancomycin in this regard. So this showed that fidaxomicin may be of comparable treatment efficacy and may actually be beneficial in terms of preventing disease recurrence. So subsequent clinical trials have looked at fidaxomicin in other settings. This is a randomized clinical trial which looked at the use of fidaxomicin for the treatment of a recurrent episode of C. difficile and showed that there was a lower rate of subsequent recurrence when compared to vancomycin. Other studies have looked at use of extended or pulse dose fidaxomicin compared to vancomycin and found subsequent decreases in recurrence of disease. And I think this really highlights some important aspects of fidaxomicin, which may differentiate it from other treatment options for C. difficile. Fidaxomicin has a very narrow spectrum of activity, which may lead to improved preservation of the major components of the microbiome, and perhaps this is the mechanism in which it provides benefit in terms of reducing recurrence. So the question comes up, if both are of equal efficacy in initial treatment, can we really target those patients who are at highest risk for recurrence, who may potentially benefit from a drug like fidaxomicin in terms of preventing subsequent recurrence? One of the main challenges of fidaxomicin at this point is the cost. It's still quite expensive, and the treatment costs have ranged, but are estimated to be upwards of $4,500 per treatment course. So I think the cost itself can be a major challenge for treatment, but the studies do show that there may be some benefit in terms of preventing subsequent recurrence. So this is reflected in the 2018 guidelines. As I mentioned earlier, the classification system changed. So for non-severe disease, which the definition I described earlier, the current treatment recommendation is vancomycin for 10 days or fidaxomicin for a 10-day course as first line. And in the 2018 guidelines, metronidazole was recategorized as an alternative treatment. For severe disease, which is defined as an elevated white blood cell count over 15,000 and a serum creatinine over 1.5, the 2018 guidelines recommend vancomycin for 10 days or fidaxomicin as the first-line treatment. For fulminant disease, which is C. difficile in the presence of hypotension, shock, or ileus, oral vancomycin, in addition to Rectal vancomycin or vancomycin administered through an NG tube if necessary is recommended. And IV metronidazole should be considered as well, particularly if there's concern for ileus. Now, in terms of recurrence, vancomycin is currently recommended as a first-line treatment, either administered for a 10-day course if metronidazole was the initial treatment, or for a prolonged taper over 8 weeks. And fidaxomicin is recommended if vancomycin was used for the initial course of treatment. In terms of subsequent recurrences, vancomycin is recommended to be administered through a prolonged taper, recommended over an 8-week period, and potentially followed by rifaximin for a subsequent 21-day course. Or fidaxomicin is recommended as a first-line agent for a second recurrence. And these guidelines are the first to include fecal microbiota transplant, or FMT, as a treatment option for patients who have a second or further recurrences. So to talk briefly about fecal microbiota transplant, so stool transplant essentially. So this was the first study that was a prospective clinical trial that showed that there was benefit in patients who had recurrent C. difficile in administering a fecal microbiota transplant when compared to vancomycin. This study was actually a prospective clinical trial that was terminated early because of the superior outcomes associated with fecal transplant in the treatment of recurrent disease. Notably, in this study, the fecal transplant was delivered through a nasoduodenal tube, which is one potential means of delivery of stool transplant, although I'll mention a few others. One other mechanisms of a stool transplant that's been proposed is through encapsulated fecal transplant. Essentially, this study evaluated capsules that contained feces from a third-party donor and was used to treat patients who had recurrent C. difficile after receiving a course of a vancomycin taper. Each patient was given 30 capsules of fecal material to ingest over a period of 2 days. And what this study showed was that among the patients who received this treatment, 70% of patients responded with diarrhea resolution, which in a very difficult to treat patient population, patients who have recurrent C. difficile, is actually quite a good outcome. The study showed that the median number of bowel movements decreased from 5 at baseline to 2 at day 3 and 1 at week 8 post-transplant. So really a very impressive outcome that showed that fecal transplant can be delivered potentially through encapsulated stool as a potential means with a very good demonstrated clinical outcome. So I think more data is needed to pursue this particular delivery mechanism, but I think raises a lot of enthusiasm for FMT. So in terms of some considerations for fecal transplant, I think there's a few things that we need to think about in trying to identify the optimal way to use this treatment. So in terms of safety data, there's been substantial data that's now accumulated showing that fecal transplant is generally safe, although there have been 2 cases of norovirus transmission that have been identified in the literature. Questions arise around who is the right candidate as a donor and who is the right candidate as a recipient. Generally, it's accepted that patients who have multiple recurrences are potential candidates for fecal transplant, but there are some studies that are currently evaluating its use in patients who have a single recurrence or even as a potential initial transplant for C. difficile infection. The donor criteria is also very important. How do we decide who the optimal donor is for a fecal transplant? Most studies have evaluated known donors, but some studies are currently evaluating third-party donors or stool banks as potential sources for fecal transplant. And other questions arise regarding screening potential donor stool in order to ensure that we're providing stool that is safe and doesn't result in the transmission of other potentially infectious diseases. The route of administration is also an area of intense study. As I mentioned, previous studies have looked at administering through a nasoduodenal tube or potentially through encapsulated stool, although a lot of clinical practice focuses on colonoscopy delivery of fecal transplant. So I think the optimal route of administration is still under investigation, and I think as we move forward, we're going to start to see a lot of different potential options for administering stool for a fecal transplant. And then the other question arises regarding an induction course of vancomycin. As I mentioned, the study that was initially published in the New England Journal in 2013, looking at fecal transplant. Actually, in that study, all patients received an initial course of vancomycin, and the role of any sort of initial antibiotic treatment prior to administering a fecal transplant is still an area under intense study. And the jury is currently out as terms of the optimal mechanism for doing this. I will touch upon one other treatment option for patients, which are monoclonal antibodies to C. difficile. 2 randomized control trials were recently published, which studied the role of monoclonal antibodies in preventing recurrence of C. difficile infection. So this, again, was not used in terms of a treatment option for C. difficile, but actually as a way to prevent subsequent episodes of C. difficile infection after a patient is initially treated. In this study, patients who were initially treated with a standard course of therapy were randomized to receive either actotuximab, which is a monoclonal antibody against toxin A, bezlotuximab, which is a monoclonal antibody for toxin B, a placebo, or both actotuximab and bezlotuximab, with an outcome being recurrent disease 12 weeks after the initial clinical cure of the initial episode. And what this study showed was that there was a lower rate of subsequent relapse in the patients who received bezlotuximab or the patients who received actotuximab plus bezlotuximab. Unfortunately, the patients who received solely actotuximab did not have a decreased rate of relapse compared to placebo. And this clinical trial led to the FDA approval of bezlotuximab in February 2017 with an indication of administration to patients at high risk for recurrence of disease. So not intended to be given to patients after one episode of disease, but potentially those patients who have either multiple episodes of C. difficile infection or have other factors that would predispose them to a high risk for disease recurrence. So in the ID community, we're still learning about how to best use this monoclonal antibody for C. difficile prevention, but I think it really highlights that even thinking beyond antibiotic administration for treatment or fecal transplant, there may be other options that we can employ in order to prevent C. difficile infection in our patients. So in summary, the 2018 guidelines really put forth that vancomycin and fidaxomicin are considered first-line treatment regardless of disease severity, and metronidazole is currently considered as an alternative treatment. There's been a lot of data that's shown that fidaxomicin may be of benefit, particularly in patients at risk for recurrent disease. Fecal microbiota transplant is now becoming increasingly utilized for patients who have recurrent disease, although the optimal delivery and optimal patient population is still under some investigation. And lastly, monoclonal antibodies may be beneficial in the right patient population at risk for recurrence and preventing subsequent recurrence. So I hope that this talk was useful in providing an update on C. difficile treatment and prevention. And I think that this is an important topic, and in the next decade we'll see further literature to support new means of treatment with the hope that we'll be able to improve care for our patients.